Okay, so good morning, everyone, and welcome to our first of 11 launch events / webinars on Introduction to Health Inequalities on our communities that relate to the new community health profiles that we've just published for 2023 to 2024. The main purpose of the session today is just to give a broad overview of the key findings from our Bisexual Community Health Profile, including a quick demographic summary in terms of age distribution, gender distribution, looking a little bit at geography for place-based approaches, then going over some key health inequalities that we've identified through a life course approach that aligns closely with the themes in the Health and Wellbeing Board strategy, a bolder, healthier city for 2022 to 2030. Important to note as well before we start that we're not going to be able to cover every single key health inequality for the entire bisexual community in 1 hour. So please just use this webinar as a good start point to learning a little bit and any future kind of like learnings that can come from this webinar. I'll quickly then cover as well, once we've gone over some of those health inequalities, some of the key findings and the key takeaways from this webinar and how we can look at incorporating some of these data and some of these inequality work into our practice, some learnings and reflections, and then talking about some of those next steps for engagement of what we would like to do with this health inequality data and some potential upcoming funding opportunities. And then we will have about 10-15 minutes for a Q&A at the end, but we will also have some interactive question time throughout the webinar as well. So it won't just be me talking to you for an hour and then a bit of chance to interact. There will be chances for questions and discussions all the way throughout. So just before we start, just some very quick housekeeping. We're going to just suggest you stay muted and turn off any VPNs just to help it run smoothly. But if you have any questions, you're more than free to kind of unmute yourself to ask, pop them in a chat. There will also be a Q&A function on the Mentimeter that we'll be using if you're not comfortable kind of asking questions or putting your name to a question. So there's an anonymised version way to ask questions if you'd like to there. The slides will be sent out alongside a recording once it's uploaded to our Healthy Brum YouTube channel. The slides will also eventually sit on our web pages, but anyone that's signed up to this webinar will get notified by email as soon as the slides are available and the recording's available to review. Okay, let's finally kind of intro. So we will be talking a little bit about the Community Health Profile Programme. I'm not going to go into any detail about what the reports are or how they were made. If you're interested in kind of the data and the research aspect of this programme, we've created a short intro to community health profiles video, about 20 minutes long if you'd like to go and learn more about the actual programme itself. We want this webinar to focus specifically on the bisexual community and the health inequalities and not spend too much time talking about kind of that background information. As I said, all of these key information that we'll be talking about today have come directly from our Bisexual Community Health Profile, which you should be able to find on our Community Health Profile homepage on our website. There is a full report and also an infographic summary page. The report's about 100 pages long, so understand that it's quite a lengthy document, but it's good if you have any particular area of interest that you'd like to go and research more about following on from today's webinar. But the infographic summary is like a one-page highlight of these key kind of data points that we're going to be talking about today. And all of the links that I'm discussing should be being put in the chat by Joe at some point. So just another quick overview of the profiles before we move on. For anyone that's not heard of them before, they're just a key set of resources that are developed by the Public Health Division at the Council. And they just look at summarising the physical health, mental health, lifestyle, behaviour and wider determinants of health-related issues in a specific community. So the main focus of these is to move away from using acronyms that just homogenise communities. So instead of saying the LGBTQ plus community, that overlooks those huge differences in health outcomes that we're going to have between those specific population groups. And that's what webinars like today and this report really focuses on highlighting. So as I said, we will be using Mentimeter today to have that little bit of interaction and that back and forth. If no one's used Menti before, you can either access it on your laptop or whatever device you're using or a mobile phone. You can either go to menti.com and enter in the code 55600407 or just scan the QR code on the screen. There should also be a link in the chat where you can directly access the Mentimeter. Now, there should be instructions on each of the Menti slides on how to join, but I'll give people kind of a couple of seconds to join onto it in case they've not used it before. So if someone could just put the link to join the Menti in the chat and then I'll move on. Thanks, Joe. Okay, so before we kind of talk about those key inequalities, I want to kind of understand where everyone is coming from today and kind of talking about who is in the room with us. So just kind of a quick open-ended question. It might be that you're here purely from a curiosity point of view, but is there anything that you're looking forward to learning or discussing? And again, if it's something that I can then kind of shift a bit more of a focus on throughout the webinar and kind of talk a little bit, focus a little bit more time on based on the interest in the room, that's something that we'll definitely be able to do. Alex, if you just click Start Menti so we can see people's responses come in on the screen. So it could be that you're coming from an organisation that works with understanding health barriers. Yeah, absolutely. And we will also be having a little bit of, not a test, but there's a little bit of a quiz aspect that we'll come to next, just kind of understanding the room, people's understanding of the community we're talking about today. Talking about inequalities, yeah, maybe highlighting some areas that we've not looked at before, health researcher, adapting services, understanding the needs, building knowledge. Brilliant, right, it's good to see that everyone's looking at learning those inequalities that they've maybe not thought about. This webinar is going to be perfect for that. So, and about how we can apply those learnings to the different services. So thank you everyone for being so engaged. So as I said, we're going to go for a little bit of a quiz now, and we're actually going to look at the Stonewall definition of bi and trying to see if people can recognise the differences in nuance and language, and talk a little bit about why language is important. And then we'll cover some other key language terms that you either may or may not have come across. So it's just a bit of a definition question. So Stonewall, if you don't know, is like a major organisation that looks at LGBT issues. And there's going to be 3 potential definitions that are correct. So we've got an umbrella term that's used to describe a romantic and/or sexual orientation towards 2 genders. An umbrella term used to describe a romantic and/or sexual orientation towards more than 1 gender, or a sexual orientation not exclusively to people of 1 particular gender. So they're very similar in terms of the definitions. But it looks like there's a clear winner here. We'll see in a second if it's correct. I think there's a couple more people that haven't answered. Yeah, so if we can show the correct answer, the majority of you are correct that it's a very small difference in language, but actually quite an important one to highlight, that umbrella term is looking at attraction to more than 1 gender rather than 2 genders, which I think is the most common assumption that people that don't know the specific definition would assume about it. But the actual definition or additional information is that bi is an umbrella term. So it might describe people using 1 or more of a variety of terms. That might include people that identify specifically as bisexual, as pansexual, as queer, and any other kind of non-monosexual or mono-romantic identity. So it's a little bit more broad than just looking at the specific number of gender identities that people are attracted to. And it is that overarching umbrella term. The webinar and the data today focuses primarily on people that identify specifically as bisexual, just because that is generally where the data is most available and where the data is generally more well collected. The health inequalities and experiences may be similar between those different bi identities, such as pansexual versus bisexual, but it's an assumption that it's not going to be exactly an identical experience across those. So just something to keep in mind when we're talking about different inequalities. So just again, a little bit more on language, just in case any of you aren't familiar with some of the terms that might be relevant to bisexual community. So you might hear some of these terms before, so just a short definition of what they are. So biphobia, in a very similar way to what homophobia or transphobia is generally that fear or dislike or that kind of aggression against someone who identifies as bi based on specific prejudices that are associated with being bisexual rather than kind of like homophobia. There's also coming out, which is specific to, or non-specific, sorry, to all LGBT identities. And it's just the definition of when someone first tells you about their sexual orientation or gender identity. And it's important to note as well that someone doesn't just come out once. And especially if you're working with people on a regular basis, either in like an academic sense or in a healthcare sense or from a community point of view, that actually people of all different LGBT plus orientations and gender identities are going to be coming out on a daily basis and going to be coming out again and again to different healthcare professionals. So just something to consider when asking those questions, that a lot of people may be having to answer these questions again and again, and having a little bit of a empathetic approach. And also one that's quite specific to bisexual people is the heteronormativity assumption. So what that is just the assumption that someone's going to be straight or heterosexual as a default option. This again may apply to other LGBT orientations, but it is so more commonly observed in bisexual people that are in what we call like heterosexual presenting relationships. So if someone is having conversations about their sexual health and are talking about their current partner being male and they themselves are female, they're going to have different medical needs than if they're male with another male partner. And it's important to kind of not assume either heteronormative, if it's a bisexual man, that is going to have the same needs as a straight man or a gay man. There's going to be different needs depending on the different situations. So a little bit about the data that's collected and a little bit about a continuation of those discussions. So in the census, which is going to be the main point of data that we're talking about today, or the main point of data that we've got and a lot of new information about the bisexual community, it was actually a new question in the 2021 census to talk about sexual orientation, and bisexual was a category that we can identify on a lot of multivariate data. So we've been able to highlight bisexual people's needs on housing, education, qualification, deprivation, which has been really useful. It's a little bit disappointing to see that, and we'll cover this more on our Monday webinar, that gay and lesbian are still grouped together in data collection methods. So it's actually really difficult to understand those unique health needs. What's also important to consider is these were optional questions in the census, unlike most that are mandatory to answer, and they were only asked to participants that were age 16 or over. So there's not going to be any data on those aged under 16 for LGBT identities. The other sexual orientation category is where there was a write-in response, and that's where we had I think 0.1% of the population put in pansexual in that category, but there wasn't enough of that variability to do that multivariate data analysis with that other category. Some of the other considerations that you may take into account when looking at the experiences of bi people is not just about that sexual identity, that's that orientation, but about specific behaviours, about sexual attraction, about relationship status. And the examples of why these might be relevant in different settings is if you're talking about sexual behaviour in a sexual health clinic, then actually sexual behaviour is a much more useful metric than sexual orientation. But if you're maybe looking at something like domestic violence support, then understanding current relationship status and sexual orientation identity might be a more useful combination of metrics to understand that domestic violence risk that we'll talk a little bit about later on today. So it's just important that there's going to be multiple different ways to ask questions around bisexual populations to understand what those relevant health needs are going to be, and it's not just solely focused on that sexual orientation. Now, with anything, there's going to be some limitations when we come to understanding these health inequalities through data. The main one being that there's going to be groupings of data. So it's very difficult to find a lot of data available specifically on the bisexual population, and then even more hard to find when it's disaggregated between like men and women, or between people that are disabled and bisexual, or people of different ethnicities. Those experiences are very hard to understand through a data lens only. So when we see grouping by data, we see that bisexual men are quite often grouped with gay men, bisexual women are quite often grouped with lesbian women. And when we're looking at health inequalities based on gender, that's sometimes appropriate. But when we're looking at specific needs, it's not going to give us the full picture. Again, and this is a similar one to all of the LGBTQ plus identities, is that specific data is not normally available, and it's either presented as a wider sexual orientation cohort, so LGB plus, or just a wider LGBTQ plus cohort. There's, say, if you read the full report, you'll see there's very little that actually specifically says this is the experience of our bisexual population. And a lot of the reports are unadjusted, so we'll see that in the demographic section, what the bisexual population looks like, and data from things like the GP patient survey are not adjusted, and this means that it might affect how those outcomes are presented and the way we interpret them. So when we look at a little bit of a demographic overview, it's useful to kind of consider when you're having engagements if this demographic data is reflective of the people that are engaged in these different healthcare settings or community health interventions. But it's also important to consider what we see on the screen might not necessarily be a true reflection. And there's going to be more research that's needed to be conducted to clarify whether there's going to be a difference in distribution of sexual orientation amongst different characteristics like faith, ethnic identities, age group, or if actually there's going to be an underreporting of bisexual identities among specific groups due to barriers to coming out. So, for example, when we look at the age category, in the census, it was identified that 45% of the bisexual population in Birmingham was from that 16 to 24 age category, compared to only 22% of the gay and lesbian population and 18% of the straight or heterosexual population. But this doesn't necessarily reflect that the bisexual population is young. It could be to do with a younger cohort having that increased social awareness and of non-heterosexual identities, and more of a safe environment to disclose and self-identify without that fear of criminalisation and pathologisation that can come with coming out sometimes. So although these are useful to consider, and I think it's important to include, just also have that caveat in mind when you are engaging with people that it might not necessarily be reflected because of those different barriers that are associated with coming out. Similarly, as well as demographics, we can look at the geography of the population for place-based approaches. And the census mapping tool is really useful for this. And I'd consider anyone that's interested in data to have a look around and kind of play around with some of the variables that are on there. But it provides a really nice overview of typically where the bisexual population in Birmingham lives. So it's typically concentrated towards the centre and the south of the city. And the census mapping tool allows us to go all the way down to MSOA level, which for those not familiar with the term means middle super output area, and just refers to a geography that has about 2,000 to 6,000 people in it. So it's a little bit of a smaller community rather than looking at ward level or constituency level. Now, it's also important to note that places where people live may not always be places where the community engage. So it's important to use a mixture of this data-led approach and also community intelligence from organisations that are going to work closely with bisexual people. Now, just a quick thing to note on the data, that the percentages that you see on screen are talking about population density. So we talked on the last slide that there is about 1.27% of Birmingham's total population identifies as bisexual, which equates to around about 11,000 people. But in Selly Oak, 7% of the population identifies bisexual, so it's more densely populated. It's going to be overall smaller populations because it's only going to be a fraction of the total Birmingham population, but this is where the community is most densely populated around the city. So that's just a little bit about the demographics of the population, who they are and where they live. And we're now going to cover a little bit about the actual health needs and those health inequalities. Firstly, I want to kind of understand people's level of confidence and level of knowledge in the room. Now, this could be really varied. There could be people in the room that work frequently with bisexual people or identify as bisexual themselves and feel quite confident in understanding their health needs. There could be some people in the webinar that are using this as a very first start point. Both of those answers are completely fine. I just would like to kind of understand whereabouts people are sitting at the minute. So it looks like we've got about a 3.1, so somewhere smack bang in the middle. So we're not really starting from that baseline perspective, but not really having that super level of confidence. Hopefully, after we've kind of gone through a couple of those key health inequalities and how we can use that to structure our work, hopefully we'll see that increase a little bit. Now, we're going to also talk about how health data is currently being used to inform your work or your decision making. As I said before, it's important to note that you might not currently do this at all, and this session could be the very first step in this direction. So that's absolutely fine. And it's just kind of wanting to know what is already being done. Then we can talk about at the end what else we can do. And it might also be useful for other people in the room that currently don't use any data to do this, to get some advice and guidance from other people in the room. Use of academic research, yeah. While that is on the screen and people are typing away a couple of their responses, I'm just going to go through a couple more points related to the rest of the webinar. So following on from this, some of the data that we will be covering, some of the topics and the content is quite triggering. So just important to note that we will be talking about mental health and suicide, domestic violence, alcohol abuse. There is going to be quite a lot of triggering content. So just be aware, if that's not something that is comfortable for you, feel free to leave the webinar and join back kind of at the end if you have any more questions, but just something to know. And when we are listening to the data in the following slides, I want people that are coming from different perspectives to consider different things as part of the discussion later. So if you're coming from an organisation that does work with bisexual people, or you're a community member, I want you to kind of think about, does the data that I'm presenting accurately reflect your kind of lived experience and your previous experience? And if not, we can kind of think about where those, why it's not kind of joining up. If you're using this webinar to learn more about kind of a new community to you, I want you to think about, does any of the data surprise you? Does it align with any of your previous knowledge? Just kind of things to think about as we go through. So let's have a look at some of the things on screen. So what do people currently do? Looking at where there might be gaps for cultural competency training, academic research, targeted services. So a big variety of how data is already used. So hopefully you'll be able to learn something new from the next couple of slides. So let's actually start going through some of the health inequalities. As I said, the topics that we're going to be covering will directly overlap with the topic areas in the community health profiles, which align with our corporate health and wellbeing strategy. To avoid it being too overwhelming for just a 1 hour session, we're only going to really be talking about one key data source per section in the report, just to avoid kind of like information overload. This should really be kind of a start point, and you can read the further information in the report to kind of develop that understanding. But the pieces of data that I've highlighted are the ones that kind of really stuck out. Either there was a really stark inequality, or the data was really available, as I said, in a lot of topics, is either grouped or it's not really clear. So these are some of the data points that we have the clearest understanding of specific health needs and health inequalities for the bisexual population. So when we're talking about getting the best start in life, we're generally talking about children and young people. As I said, many data sets only collect sexual orientation for those aged 16 and over. So data on bisexual young people is normally quite limited. So in the report, the only thing that we have a clear understanding of from the data at the minute, and this is all publicly available data, I should mention, is about mental health and wellbeing. And we're talking about the Youth Chances project from 2014. So it included almost over 3,000 lesbian, gay and bisexual young adults, 16 to 25, and then reported on specific risk within those categories. So the data that we see on screen is specific to the bisexual community. So for lifetime suicide attempt, suicide ideation, and future suicide risk, we're looking at almost a 2 times higher risk among bisexual young people, and that's compared with lesbian and gay youth, which already have heightened inequalities when it comes to experiences of poor mental health compared to heterosexual peers. So this is really kind of a compounding inequality, and as it kind of says on screen, LGBTQ plus young people have a high degree of mental health problems compared with heterosexual peers. And the qualitative data for this isn't as robust, but there are a huge variety of reasons when you think about social exclusion and not having that solid community, homophobic and biphobic bullying, especially in schools. LGBTQ plus young people have really high experiences of bullying in school, which can contribute to poor mental health, unsupportive family groups and support circles. There's a lot of factors that can contribute to poor mental health, but for those that are keen on data, I've also included the odds ratios and the confidence intervals. But for those that are not as keen on data, it's around about a 2 times higher risk of, as I say, suicide attempt risk and future ideation compared to lesbian and gay youth. So really stark inequality there. When we move on to mental wellness and balance, the same picture is seen for adults. I didn't want to kind of rehash the same experiences, but poor mental health does continue into adulthood. In the GP patient survey, 40% of bisexual respondents listed a mental health condition, compared with 27% of gay or lesbian respondents and 12% of heterosexual respondents. So again, that does continue into adult life, and there is more data on mental health of bisexual adults in the profile. Something else I did want to focus on for this webinar was substance abuse, specifically looking at the Smoking and Alcohol Toolkit series that are run by the University College London. And the studies typically consist of like monthly national household and face-to-face surveys of the adult population in England and follow-ups by telephone. So it's a pretty comprehensive study. And they look at 2 different platforms. So when we're looking at hazardous alcohol consumption, the statistics that you see on screen are for those that score an 8+ on the alcohol use disorders identification test, which is just a widely used alcohol screening tool from 1989 based on data from the WHO. And it asks questions on alcohol consumption frequency, on volume, on behaviours such as like guilt and regret, and those associated factors. It's a short 10-question survey on like a Likert scale, and then they give kind of like a hazard score on whether or not someone is having hazardous alcohol consumption. For the bisexual population compared to heterosexual, there wasn't data that I could find on lesbian and gay. 24% in both men and women for 2014 to 2016 were reported as having hazardous alcohol consumption, which is a few percent points higher than for heterosexual men, and especially the difference for women is very stark. So 8% of heterosexual women with hazardous alcohol consumption compared to 24% of bisexual women. And again, that stark difference between women is also seen in smoking. So again, when we look at the raw statistics, 28% of bisexual men and 30% of bisexual women were identified as current smokers, and this is from 2013 to 2019, compared to only 20% of heterosexual men and 17% of heterosexual women. But as I said before, a lot of these statistics are unadjusted, and when those variables are adjusted in data, those statistically significant differences in that hazardous alcohol and the smoking is really observed for women. So this is the key difference, is the difference between men and women, is the difference between women that are bisexual compared to heterosexual. The smoking prevalence for gay and lesbian men and women is again still typically a little bit higher than for heterosexuals, but for bisexuals that was kind of and again another really stark inequality that was identified in our research. There is a little bit of a limited understanding again for that qualitative available data on why, but I say a lot of studies do link poor mental health and that social exclusion to hazardous alcohol consumption and smoking. So those are some potential links, but that's not, we don't kind of have that qualitative data to say for certain this is exactly what contributes to that. When we talk about food, there is really limited data when we can talk about health inequalities here. There is very limited data on national surveys collected on food and diet, specifically reported by sexual orientation. So there's no national database source that I can pull from here. But there are a couple of smaller peer-reviewed journal articles that talk about eating behaviours, and it has been highlighted that bisexual people were more likely to engage in different disordered eating patterns, such as binge eating. Bisexual men in particular were at higher risk for eating disorders compared to heterosexual men. Bisexual women specifically were associated with behaviours such as fasting, use of diet pills, laxative uses, skipping meals. And overall, for both bisexual men and women, there was greater body dissatisfaction and weight and appearance concerns compared with heterosexuals in the identified studies. When we look at activity and active lifestyles, this kind of highlights the importance of disaggregating data by further demographics such as gender, because you'll see, and I'll talk a little bit more about the charts, but there is a bit of a difference in physical activity experiences of bisexual men compared to bisexual women. So this is all looking at the active life survey, and anyone that's classified as physically active is someone that does 150 minutes or more of moderate physical activity per week. This can also be measured by 75 minutes or more of vigorous activity per week. Moderate activity is defined as anything that raises the heart rate. So a brisk walk or cycling is enough to classify as moderate physical activity, whereas vigorous is anything that is really high intensity, so running. So bisexual people, on average, when we look at just that headline statistic, reported higher levels of physical activity than heterosexual people. So 66% said that they met the guidelines compared to 62% of heterosexuals. But when we break that down by gender, we get two very different pictures. So when we look at bisexual men in particular, they were the least physically active compared with other sexual orientations compared with men. So they were less physically active than heterosexual men and gay men. Whereas when we look at women, lesbian and bisexual women had the same physical activity levels, and they were both considerably higher than heterosexual women. So it's important when we have that data to show that there's going to be stark differences between not just bisexuals versus other sexual orientations, but actually between those different characteristics. So like gender and sex, maybe like, as I said before, disability, ethnic group, all of those different factors are going to contribute to the way someone experiences health and well-being, and is going to have a very different experience, even if the data doesn't necessarily reflect it. When we move on, we're talking now a little bit about long-term health conditions and disability. So in the GP patient survey, they look at anyone that reports a long-term health condition, a disability or an illness. And again, we look at this is much higher in the bisexual population compared to the lesbian and gay and the heterosexual population. So those statistics are not just mirrored in the GP patient survey. There is similar findings in the 2021 census about those that are classified as disabled under the Equality Act. And again, that qualitative data as to any links between orientation and or specific bisexual identity and long-term health condition and disability were very limited. But we've got a couple of research that show that we're more likely to see bisexuals report long-term health conditions or disabilities. Again, this UK household longitudinal survey shows around about 2 times more likely to report this compared to heterosexual people. Now, in Protect and Detect, I'm looking specifically at sexual health data. Now, this is the one area of the report where there was very limited data on specific bisexual experiences, and this was almost entirely grouped bisexual men with gay men and other men who have sex with men, and bisexual women, on the same note, were also grouped with lesbians and other women who have sex with women. When we look at the STI risk, though, it's difficult to understand if there's a difference in specific STI risk between bisexual men and gay men, for example. But as a whole, when we're looking at that sexual behaviour, if there's a bisexual man that is currently have sexual behaviours with other men, there's going to be that increased sexual health risk. So in terms of new STI diagnosis from the UK HSA, we're looking at around about an STI prevalence of 7,000 per 100,000 among those bisexual, gay and other men who have sex with men, compared to 291 per 100,000 for men who have sex with women. So again, when we talk about that bisexual orientation, bring it back to the start point when I said that sexual behaviour may be more relevant here. So a bisexual man that is currently got exclusively female partner or partners is going to have a much lower STI risk than if there's current male partner or partners. And that's again similar for specific diagnosis. So if we look at, for example, the HIV risk between bisexual and heterosexual men and heterosexual and bisexual women. Bisexual men have got a roundabout prevalence of 0.32% HIV compared to 0.04% of women. So in this cohort, the bisexual and heterosexual women prevalence, there was 185 identified cases out of a cohort of 441,000, whereas the males, there was a incidence rate, there was 463 identified cases out of 144,000 in the cohort. So that's where those kind of specific numbers came from there. And then we finish off looking at the end of the life course and the ageing and dying well. Again, there's very limited data specifically on the older bisexual community, and in general, very limited data on older LGBT populations as a whole. One of the factors that we have looked at in this section of the report is loneliness and isolation. And it is important to note that although loneliness and isolation is not exclusive to older adults, there is a data that shows that risk of loneliness and the social isolation increases with age in all population groups. So the experience of loneliness and isolation among older bisexual adults statistically is going to be far more prevalent than among younger bisexual adults. So we go back to the GP patient survey for this one, where we're looking at around about a quarter of bisexual people reported feeling isolated or lonely in the last 12 months, which was higher again than both the lesbian and gay populations at 17%, and then again much, much higher than that heterosexual population at 8%. Now, there are some researchers that suggest that bisexual people are at a particular risk of loneliness and social isolation, even compared with other sexual orientation groups like lesbian and gay populations. And some of those risk factors I've listed on screen. So there is often that limited social network between bisexual communities compared with the social networks among lesbian and gay communities. There's typically fewer social support groups and spaces specifically for older bisexual people. There's experiences of biphobia limiting the ability to come out, and what some reports have referred to as the double closet, which is sometimes experiences of discrimination from both heterosexual and other LGBT communities based on some of the stigmas and some of the assumptions of the bisexual community. And again, looking at how those mental health statistics we talked about earlier can compound different areas of health and well-being, and that can also contribute to those feelings of loneliness and isolation. So there's a lot of those inequalities that we've covered. This is not, and as I'll reiterate really importantly, this is not a full comprehensive understanding of all of the health and wellbeing needs of the bisexual population. And there's a couple of other statistics on screen that were really prominent in the report that I've not had a chance to talk about in detail. So for example, the Crime Survey for England talked about bisexual women were much more likely to experience domestic violence compared to heterosexual women. It was around about a quarter of bisexual women had reported experiences of domestic violence compared to 7% of heterosexual women. Similarly, with the mental health statistics, there was a really high prevalence of self-harm. So Stonewall in 2018 reported that more bisexual women in the last year had reported self-harming behaviours, and that was at 28% of the community, higher than both bisexual men at 18%, at lesbians at 14%, and gay men at 7%. So again, those stark differences in gender as well as just identity. The use of other illicit drugs also following on from the smoking and alcohol abuse. In the previous year, 37% of bisexuals had admitted to using illicit drugs, again compared to 25% of lesbian and gay populations and 11% in heterosexuals. And throughout this report and a lot of the other LGBT reports that we've highlighted across our community health profile programme, there is typically that lack of understanding from healthcare professionals when different LGBTQ plus populations are accessing healthcare, and understanding the specific and unique healthcare needs that come along with each one of those identities, and not just assuming that LGBTQ plus is one group that has one specific approach and one specific health need and story. So these community health profiles, as I said, are a start point for building co-produced solutions, and it's not going to be a fully inclusive document that will accurately map the entire experience of the bisexual community. But what this report will do, and what we encourage people to do, is look at one of the particular topic areas where we have highlighted that high-level data in an area that you're particularly interested in, and use it as kind of like a snowballing to go and look at the other more in-depth research in that particular area. And it's also an important note to, when we're talking about health and wellbeing needs, to decrease the stigma and the discrimination associated with coming out amongst bisexual populations, and avoid those heteronormative assumptions that we talked about earlier, to make sure that the data we collect and the conversations that we have accurately map and understand bisexual people's experiences with health and wellbeing. So I'm aware that I've kind of spoken at you for a while, so we'll go back to a little bit of that two-way discussion, or a little bit more of that interactive side. So from kind of like an overview, thinking about those things we talked about earlier, does that map your previous experiences, your previous understanding? Was anything surprising? But just overall, do you feel like there was something that you've learned that makes you feel a little bit more confident in understanding what bisexuals' health needs are compared to potentially other sexual orientations? So do you understand the differences between needs of bisexual populations compared to lesbian, gay, heterosexuals, for example? Now, I don't expect people to come away from this webinar and go, right, I'm now an expert in this topic area. Absolutely not. So this is very much, say, a whistle-stop tour, and hopefully you'll have some time afterwards to reflect a little bit on what we've talked about and do that further kind of research and further understanding. But I think the score has gone up a little bit, which is helpful to see. So I'll give it just a second, and then we'll move on to kind of what are the next steps and what can we actually do practically from this webinar going forward. So what can we do to take this forward? So the next opportunities for engagement that we have is actually going back to the profile as a report. So the Bisexual Community Health Profile is still currently in its draft version. So if you go on the website and look at it, some of the formatting might be a little bit off. There will be a big draft watermark on it, but that's for a very important purpose, is that we want to kind of have these conversations first and make as many people aware as possible and engage with the report, because we want people's feedback. If you are someone that identifies as bisexual or works with the bisexual community, I mentioned at the start, I want you to think about, does this align with your previous experiences and understanding? If not, we'd be more than willing to have like a discussion to understand, is there a particular area of health that is important to this community that we've not included in the report that you actually think is really important for organisations and healthcare professionals to know about? And we can definitely include that in the final iteration. Is the language that we've included appropriate? Is it inclusive? Do you feel that it's reflective and appropriate for this community? If you're coming from like an academic point of view and you have a really useful piece of research that you'd be willing to share or that's publicly available that we've not included in our full report, please share it with us. And we want to kind of make this as strong of a start point for people to understand the health and wellbeing needs of the bisexual community. Now you can just give any feedback via email. So we have our community's inbox, which someone can pop in the chat. Or if you'd like to, you can book onto a feedback session. I've not set up the dates yet, but if you want that kind of more face-to-face discussion, we'd be more than happy to facilitate that as well. Now, a little bit just of a checklist. Again, this isn't a complete comprehensive checklist of everything that we can do. It's just some suggestions of what you could do following this webinar. So in terms of the actual data and those health inequalities, looking at that full report and thinking, have you shared it as wide as possible? So have you read it yourself? Have you shared it with any team members that might be interested in learning more about the health inequalities of our bisexual population? Have you shared it with the wider organisation? Any partner organisations that you think might be interested in learning more about this information? And now, how can we actually use this data going forward? So it would be useful to see if people are looking to create more health and wellbeing services or do more research on the bisexual population, that potentially people refer back to this profile as a start point. We really encourage anyone to use these health inequalities to help build really relevant and appropriate services and projects and health inequality projects related specifically to bisexual populations. It's useful to talk about these health statistics, and anyone in this room to become like an advocate and said, these are the health inequalities, these are really important, we need to tackle these. And also just use some of the understanding and the findings to think, how can I make my practice more inclusive? How do I make sure that I'm asking the right questions? How do I make sure I'm having conversations using the right language? How do I make sure I'm considerate of these different experiences that people might be having based on the inequalities we've talked about today? So just a little bit more about kind of going forward and again, sharing some of that learning. So if you can't think about any particular examples right now, that's fine, but it might be useful to share some learnings. If someone else has a really useful idea of what they plan on doing, it might be useful to kind of share that with the room and see how can we kind of move forward from here. So is there any way that immediately from what you've learned today that you think you can incorporate this into your work, your personal practice, or your wider organisation? Yeah, definitely would recommend looking at those gaps in the evidence and using that to think about where can we fill in those gaps, especially if you're coming from an academic point of view. That may be a really useful area of research to delve a little bit further into. And that's definitely something that we are also considering when we've mapped out all of these different reports, is where do we not have that information and how can we go about getting that information one way or another? It's good to see that people are looking at it from how we can make services more accessible for specific communities and informing kind of our decisions going forward. Really useful to see. Brilliant. I would love to see this shared kind of as widely with as many colleagues as possible. Thank you. And another quick question is kind of, if you have previous experience or from this webinar, how do you actually want to see more inclusive healthcare services? Is there any particular methods or any particular insights that you have on, or any particular things you have just from learning today? How do we want these healthcare services to be more inclusive and supportive? Is there any particular things that come to mind here? Yes, absolutely. I think that's a really important assumption, that regardless of what line of work you are in or what organisation you're from, that when we're talking about health needs of specific LGBTQ plus populations, that we're not putting that assumption of heterosexuality onto people. And that's not just exclusive to bisexual populations, as I said earlier. It's just assuming that is for a wider LGBT. Absolutely. That co-production is a buzzword that I think we all love at the minute, but it is important to actually make sure that the services are shaped by the people that they're serving, and that it's not just kind of decision makers making those decisions on behalf. I think that's a really important point that someone's put in the Menti about considering people's health needs based on an individual, and that's absolutely right, and something that I think it's important regardless of what identity we're talking about. So whether or not it's a sexual orientation or a gender identity or an ethnic group, that people at the end of the day are still individuals, and it's all right to have that culture of humility and understand that there are going to be limitations to our understanding, because people are so unique and complex that just asking people kind of what their specific health needs are is going to be kind of the best approach regardless of which community we're looking at. And yeah, that follows on quite nicely that point that's just been put in about intersectionality, that it's not going to be identity in silo, that's not going to be the only way that people are interacting with health and wellbeing services. And I think that's something that we can all take on as well from this webinar, is making citizens feel more comfortable in being more open in disclosing identity to help support properly. So I think these are all really useful things. And finally, on the Menti, is there anything else that would be useful from your work's perspective and your daily practice? Is there any other intelligence or resources that would be useful for you to help you inform your work on addressing any of the health inequalities? Looking at whether there's anything that we can support with or any other organisations. Is there anything else that you think I would like to see X or Y? You can't think of anything off the top of your head, we'll leave this question running in the background and we can always come back and reflect on this at a later date. So, well, there we go, one question. Yeah, so looking at kind of anticipating our needs, is that kind of talking about what maybe gaps we have, or what needs evidencing, yeah. Perfect. I'll let that run in the background for a bit, just so we can kind of close up and have time for a little bit of discussion. So one thing I want to highlight for any organisation that might work with bisexual populations is we do have an upcoming funding opportunity as part of our Deep Engagement Partner Programme. Now, we weren't able to have separate lots for separate funding pots for every single LGBTQ plus identity. So we are going to be funding an LGBT plus partner and a trans partner. But it is important that within that project, we expect there to be specific and separate interventions for gay populations, lesbian populations, and bisexual populations. So that work will be separate based on kind of the approach we've talked about today. There is an opportunity for a 2-year contract plus a year extension. So we've got 3 years in total available, and the project is predominantly focused on sustainability and upskilling community members and community organisations. If anyone's interested in that, we do also have a webinar on a little bit more detail about the programme, but for a rough estimate, it should be going live around about the end of March, or round about the beginning of March, sorry. So if you'd like more information, you can either again email us or look at that webinar, which hopefully someone can put in the chat. So that is pretty much everything for today. So we're just going to have a little bit of closing up and discussion time now with the final 10 minutes. So this, as I mentioned, is the first of 11 launch events that we've got. So if you found today useful, I would highly encourage you to go to our Eventbrite page and sign up to one of the other 10 webinars that we'll be delivering, again, on specific communities. If you've found today interesting, you may find Monday interesting, where we talk specifically about gay men and look at other men who have sex with men. If you can't make any of the live webinars, they will all be going live on our Healthy Brum YouTube channel. And if you're not currently subscribed to it, we can talk about how you can get updates for this information going forward. Now, just quickly as well, we've got some partner organisations at University of Birmingham that are currently doing an evaluation of the community health profile. So if you've used them previously in your work at all, there will be a survey going around soon, and we'd really appreciate anyone that is willing to take part in that. So that brings us to the end of our webinar. So we're going to just go through a little bit of a Q&A. So if anyone has any questions, there should have been a section on Menti as well, if anybody wants to ask anonymous questions, or if anyone wants to kind of raise their hand and speak, now is kind of your time. I'll give it a couple of minutes, and if there's no questions in those couple of minutes, I'll turn off the recording if anyone wants to ask anything that's not going to be recorded. Okay, if there's no questions immediately, I'll turn off the recording in a minute, and I'll just go through the last kind of couple of how you can kind of stay in touch. So again, our communities team inbox should have been put in the chat by Jo, and it has, thank you. Everything will be available on our Community Health Profile homepage. And also, if you would like to be aware of any future webinars that we hold, any other engagement opportunities, any other kind of funding opportunities or resources that we have, please sign up to our mailing list, as that's where we kind of send all of that information out. And we would really appreciate some session feedback. So Jo has popped the Microsoft Forms link in the chat. I will post it as a separate link just below, and I would really appreciate any feedback. It only takes about 5 minutes, and it's just about how you kind of found the experience, so we can make sure that our webinars going forward are as engaging as possible. I will turn off the recording now, just in case anyone has